for folks watching this on YouTube, you were talking about the difference in price between doing some procedures like MRIs in a hospital as opposed to a satellite.
I call it a community-based. I call it a community-based market-priced ambulatory center.
Right, okay, and it's so huge, and as you said, some of your doctors said 75% of the cases that are done in hospitals could be done at an ambulatory. There are some that you want them in the hospital. So the question is, why wouldn't the Affordable Care Act, or why the Affordable Care Act plus everything that's happened since, why hasn't that problem been solved? Why aren't there more of these cases going there? Where's the friction? Where's the resistance here?
Well, the resistance is in part, I think it's status quo. People like what they've always done. A lot of hospitals and health systems don't have the ambulatory network that, say, MemorialCare has. We have over 70 of those types of locations out in the communities that we serve, and we're really passionate about that. Even though it's negatively impacted our bottom line, it's the right thing to do, and we believe the market's going there, so let's get there first. But Medicare in 2015...
So now you just made a profound point there, okay?
It's the first of the week.
Everybody could say, no, kudos to you, you're doing this, although you do admit you're not doing it. It's the right thing to do, but you think it's also going to be, in the long run, the prudent thing to do from a financial standpoint. But right now, I would think many hospitals then are just saying, when it's time, we'll do it. But for now, we're going to keep doing it in the hospital because we're making more money.
They could.
I mean, those are my words, not yours. But
enough.
I'm seeing that's a problem. That's a problem in the system.
The system is pushing back, though. In 2015, Medicare's known this forever. Even Medicare pays a different price. Theirs is not 200 or 300 or 400%. Theirs is 25 to 50% more, but it's still more. Same procedure, same doctor, same patient. I mean, why does Medicare do that? So finally in 2015, in the Budget Reconciliation Act, they said we're going to implement what we call site-neutral payments. We don't care where it's done. If it's an ambulatory procedure, we're going to pay the same amount. But they got a lot of pushback from a lot of my colleagues. And so they compromised and said, okay, we're going to grandfather all of the existing hospital licensed imaging centers and surgery centers, but for any new ones, we're going to pay a different rate. However, Anthem started saying, you know what, we've had enough.
Anthem,
the big insurance company, and they started in January of this year, where they said for MRIs and CTs, outpatient, we are no longer going to pay for them in a hospital imaging center unless there's a clinical reason that they're there. That was a big, big move. We're going to see the other health plans follow. Then we're going to see all these health plans say, okay, this makes sense now. It's more value, it's more efficient. So why are we just limiting to MRIs and CT? Let's do all imaging modalities, and now let's include ambulatory surgeries as well. I think we're moving in that direction.
So are you overall pretty are you optimistic, pessimistic about what's happening?
You know, I have to be optimistic. I mean, I love this industry, and it's complicated, it's frustrating sometimes, but the movement toward value, which is kind of the quality as the numerator and cost as the denominator, and we can measure both fairly well. The focus on that is more employers are saying, I cannot pay for a stomach a 6 or 8 or 9% increase in our premiums for my employees. I either have to pass a whole lot more cost to them, which can help in the short term, but in the long term is not good. Most people don't have that kind of money to be able to absorb that unless they're really good savers. So we're really big fans of these accountable care organizations and value-based plans where you align the incentives of the employer or the payor with the providers, wherever possible with the employees. An accountable care
organization, what's that? How's that different than an HMO or something?
Well, it's where you say, I will take responsibility for this population of patients, whether it's a corporation like the arrangement we have with Boeing. We're taking care of the Boeing employees and dependents who have signed up with our program, and we have an agreement with Boeing that says we're going to bend the cost curve, and if we don't, we eat it. And we're going to hit certain quality metrics, certain patient satisfaction metrics. They want nurse triage, they want telemedicine, and we're required to deliver all that. Right. As more employers move in that direction, I think the system will begin to go where it needs to go.
So in let's say 10 years, and when you're feeling optimistic, 10 years, what will our U.S. healthcare system look like? I'm
hopeful that it is a blend of the much like we have with the public and private, but it is entirely focused on paying for value. That the idea that we used to pay, as we still do today and have for decades, for volume, where hospitals and physicians, when patients come in, they get paid. When they don't, it's their own business. We want to be responsible to keep people healthy, and we want the economics of the system to reward that, or the system won't work. And so as we move down toward that path, toward these value-based plans, that's where I think we'll be.
You said in the show you're not a fan of single payer. As you know, there's a substantial number of politicians in California who would like to have a single payer system. The legislature, in fact, actually the Senate, I believe, state Senate,
and the leading
voted
candidate
a single
for the
payer,
governor.
and then they pulled it when they knew the governor was going to veto it, and everybody was getting upset. But what are the chances that we're going to wind up with a single payer system, either in California or in the United States?
I don't think it's high, and certainly not anytime soon. And I'll say why. With California, I mean, it was a fairly easy question of economics. I mean, it was estimated by a nonpartisan independent group to cost $400 billion.
A year.
A year.
Which is more than the whole state budget.
By a long shot.
Yeah.
So, but in fairness, they assumed $200 billion would come from the money spent today by the state or the feds for current health care, for Medicare and Medicaid. Right. Of course, that would require California petitioning the federal government and saying, all the money you spend for California citizens for Medicare and your contribution to Medicaid, give all that to us. I don't know that the feds are going to do that. We're 1/12 of the population. That I don't think it's going to happen. Right. But let's assume it did. How do you fill the other $200 billion? Well, there's a few ways. Increased income taxes. We're already the highest in the United States. I don't know how much higher it can go. Increase sales taxes, increase property taxes, increase payroll taxes, or create a gross receipts tax where every product that a car manufacturer...
More taxes. It would have to be...
Endless more taxes. And what concerned me was the advertisements while they were pushing the single payer. In California, one of them said, you can see any physician, anytime, for anything you want, and you don't have to pay for it. Well, that sounds wonderful. But it's also...
Sign me up.
It's also kind of silly. Yeah. I mean, there's got to be utilization controls, and it just concerns me handing over a system like that to any government. I mean, think of the VA. The VA system is not serving our veterans well, and that's a government-run system. It's not. And Medicare, I just mentioned traditional Medicare, according to independent analyses in DC, is on a glide path for insolvency. Is that who we want running the healthcare system? I'm not a big fan.
Okay. Well, again, Barry, always great to have you on. Always great
chatting. Good to see you again.
Thanks much.
You bet.
Yeah.